this is yellow, and they can assay it in blood. It turns out that there are several situations where nitroacetaminophen can be formed in vivo. One of them, of course, is in the stomach at low pH where there's abundant nitrite, and the other is in the lungs. These are data from John Hunt from over a decade ago looking at airway pH by exhaled breath condensate being low in the context of an acute viral infection associated with an asthma exacerbation. With corticosteroid treatment, the pH comes up. And subsequently, he has a substantial amount of data that in the context of acute infection, whether viral or tuberculosis or pneumonia or CF, actually CF exacerbation, the airway becomes acidified. The acidification can lead to Tylenol nitration. Nitroacetaminophen, in turn, can be a potent hapten for whatever allergen is around. And so the Hunt hypothesis would be that a viral respiratory illness with fever leads to acetaminophen use. In the context of a lower airway pH, this makes nitroacetaminophen. In the context of an aeroallergen, this ramps up the allergic response to dust mite or roach or whatever is in your airway. And then repeated use leads to severe refractory asthma with continued exposure. Is that right? I don't know. But whether it's from hygiene or acetaminophen or other causes, asthma affects a broad cross-section of the world's population, not defined by a specific race or ethnic group or genetic group. In non-severe asthma, by definition, routine treatments are effective. So the heterogeneity is less important in severe asthma. You just give them inhaled steroids and or leukotriene receptor antagonist and treat with albuterol, and things are good. But in severe asthma, understanding the heterogeneity can affect therapy, and that's what we're about in the SARP. So what are the determinants of heterogeneity in asthma in general and severe asthma in particular? And I'll start with a very simple one, and that is gender. I think everybody recognizes this, but these are the severe asthma data. These are the SARP data. These are X's and O's for Mike. The X's are severe and the O's are non-severe. There's really no difference. If you're female, you're more likely to develop severe asthma or non-severe asthma as you grow older, and if you're male, you're less likely to have it. And that's one of the things we'll study longitudinally in SARP-3. SERPL has nice data that eotaxin-rich progenitor cells actually home to the lung with follicular activity in the ovary, and that that may explain this repeated insult with eotaxin-rich progenitors to the lung, may explain this worsening likelihood of having asthma as you get older if you're a woman. But we're not sure. But I want to look in terms of the context of the many determinants of severe asthma, important for developing targeted therapy, at this relationship. So Serpel-Erzer looked in the whole Cleveland metropolitan area at asthma at different ages. And these are all the patients in all the systems reporting in Cleveland. And we saw very much the same pattern. As you get older, if you're female, more and more likely to have asthma. As we know, early on, there's a few more, it's slightly more likely to have asthma if you're a boy than if you're female. I'm going to use this as a background. I'm going to turn this on its side and use it as a background for discussing other asthma determinants. Okay? Everybody with me? All right. Menstrual asthma is probably not going to happen in males. We have some evidence that high VEGF is more likely in females. Interestingly, there's the increased bronchial circulation story. There's a patient I follow in West Virginia, a Cherokee woman with cystic fibrosis, and she has hemoptysis every month at the time of her period. And I don't know if that's your experience as well, but I think there's probably some truth to that. We didn't really study smokers in the SARP. They certainly have in the European networks, but as you get older, and especially in males, it's an issue. But the big population is the classic allergic patient with many subdivisions, right? So that if you're allergic, you're much more likely to have asthma. And the genetic determinants of allergy are a big important part of asthma. The people in San Francisco are very interested in mucus hypersecretion in the IL-13 story. I'm very interested in high S-nitrosoglutathione reductase, much more common in allergy. Obviously, Elliot has done elegant work over the years on high leukotrienes, and with Bruce, low lipoxins turn out to be a very important phenotype. High asymmetric dimethylarginine, low pH and low glutaminase activity, chitinase-like protein story, chronic infections. The Wisconsin group was very interested in this, and not just in mycoplasma chlamydia, but also in viral infections, and on, SOD, and so forth. And arginase. Sally Wenzel's been very interested in the tryptase kinase positive mast cell story. And we all write grants on these things, and we all talk about how these are relevant to severe asthma and how they're relevant to asthma in general. But my question is, I put all this ugly slide up with all these colors that don't match, is this. Can you take this heterogeneity and divide it into 5 unbiased clusters? And my answer is no. No. What you really want to do is look at people who have, whether genetically or biochemically, who have high leukotriene activity or low lipoxin activity, and target that group. All right? Yes, clusters tell us about asthma heterogeneity, but I think it's the wrong approach. So here's an analogy for Mike, okay? So here's the line of scrimmage. All right? And so you get a call on the Ernie Adams phone saying, I've done a mathematical analysis. And I can divide the defense mathematically into 5 clusters. Here they are. And I can tell you that in this cluster, you only have a 40% chance of having a defender there in the next play. So just check it in that direction and see what you get. And I think the response would be, come on, man, that's the wrong approach. What you want is to throw the ball the right place in a very precise, targeted therapy, and that's how you're going to be successful. All right. So I favor a biased approach, not an unbiased approach. Targeted therapy for severe asthma phenotypes, the medical paradigm. First, suspect the phenotype based on clinical data. So this is like treating strep throat. I mean, it's a pediatric analogy, but so you know what somebody with strep throat looks like. You suspect that they have strep throat and not mono or not a virus. And so then you do the medical test, right? You say, okay, yes, I was right, or no, I wasn't right. That phenotype is right, or it's not, or my guess is wrong. And then you treat the phenotype in a very targeted, directed way. That's what we do as doctors. So that's what I think we should begin to do in the SARP-3, and I'm going to give you some examples next. The eosinophilic child, the non-eosinophilic adult with high BMI, GER symptoms, and low FeNO, and the allergic patient with childhood onset asthma and normal baseline FEV1. All right, let's start with example 1. So we know from Ann Fitzpatrick's work at Emory that severe asthma is generally simpler in children than in adults. All right, that is to say that things are very complicated when you get to adulthood, but with kids, the black circles are severe and the white circles are non-severe. The children with severe asthma consistently have lower FEV1, consistently have higher FeNO, consistently have higher IgE, or more allergic, and depending on what their FEV1 to FVC ratio is, they're more likely to have exacerbations. And people with kids with allergic severe asthma that's refractory are much more likely to wind up in the hospital. For kids, it's relatively simple. Allergy, eosinophilia is more common. And so Serpil, Erzurum looked at a marker for eosinophilic inflammation, overall marker, which is bromotyrosine. So as you know, tyrosine can be modified in a variety of ways, but eosinophil peroxidase forms bromotyrosine, particularly in the context of oxidative stress. Neutrophil peroxidase will make chlorotyrosine. You can measure this in the urine. And she did, and she looked in the urine of a large number of children, so recently published in Journal of Pediatrics, and found that the higher your urinary bromotyrosine level, the more likely you were to have subsequent follow-up symptoms six weeks later, and or specifically exacerbation. And urinary bromotyrosine was a much better predictor of who was going to exacerbate among children than among allergic children than was exhaled nitric oxide or FEV1. So could you take allergic children with eosinophilic airway disease and follow and say, okay, this phenotype I know to be somebody who actually needs more steroids than what we're giving them, or as is commonly the case in childhood, is not taking their steroids, and then treat that aggressively and prevent exacerbations. So that would be one kind of model of how we could use this. Okay, so the phenotype is eosinophilic allergic airway inflammation in children. We'll test with bromotyrosine, we'll follow it longitudinally. Andy Bush has shown nicely that about half of kids don't take their steroids. And so can you use that as a marker for who's not doing their therapy, by the way? All right, another example. Exhaled breath condensate pH is low in many people acutely admitted for asthma, but in a subpopulation, 7% of our 541 stable SART patients with asthma had low breath condensate pH at baseline, less than 6.5. This was, it's kind of a long story, but associated with decreased airway glutaminase activity, with the airway somewhat recapitulating the kidney. What did the phenotype look like? High BMI, low FeNO, GER symptoms, and low serum eosinophils. So there's the strep throat phenotype. We say, okay, this seems like somebody walking into clinic with severe asthma who may have airway acidification. We can do a test. It turns out EBC-pH is probably not the best test to use in that phenotype. And here's an example of why. So if you protonate nitrites, you make nitrous acid, which evolves nitric oxide. If you take somebody with asthma and give them inhaled buffer, their exhaled nitric oxide decreases, not so at different flow rates, and not so for somebody who doesn't have asthma. And looking at the change in FeNO in the population of healthy mild asthma and persistent asthma, there is a subpopulation with a significant decrease in FeNO after inhaled buffer that can be a marker for airway protonation using this simple chemistry. So in this sense, the phenotype leading to suspected diagnosis we've described. A test would be a buffer challenge or EBC-pH. The treatment would be inhaled buffer or glutamine. Relative to children, nebulized asthma medicines like albuterol and ipratropium tend to be at pH of about 3. So even just nebulizing the acidic treatment in children may have a hidden adverse effect. Low pH is associated with increased cough, poor ciliary clearance, and increased apoptosis of inflammatory cells, but also of epithelial cells. So there may be a particular disadvantage. So